Everybody, we started early, so everybody just please hold off. Thank you.
My camera.
Everybody can mute and camera.
Yeah.
Little
Yeah,
button
yeah,
right there.
watch.
Okay, did you sign into the one that he sent you, or
Yeah,
just sign?
no, I signed in the
okay.
one he sent me.
Maybe if you click the webcam
Yeah, I
right
did that
there,
too.
and what does that give you? Option was
Nothing.
the little arrow. Oh, you closed it, huh? See, try the green again, or I mean, right below it. There we go.
Oh, no.
Oh, for a second. Apologize.
All right, welcome everybody. Thank you for joining us today. I am sharing my screen to start, and I have my presenters with me now. Sorry for the confusion as we got started here. This webinar / fireside chat is going to be from data to performance, how a leading ACO executes quality reporting at scale. Couple things before we get everything started. First off, I'd like to introduce the team that's on the call today. I'm Mike Lewis with Health Monix, VP of Customer Success, and I've actually had the luxury of working with this team for 4 to 5 years, I think. We're moving here. So Dr. Zachary Men and Dr. Julia Andrini and Wajia Wahid from Houston Methodist. And then we're joined by Senior Director of Health Systems at the American Heart Association, Veronica Sanchez. So before we get started with the party here, there are handouts on your widget if you take a look at that, as well as if you ask questions. We'll hopefully have the opportunity at the end of the webinar to get to those questions. Otherwise, we'll be sure to reach out to you by the beginning of next week with any questions. So without further ado, I am going to pass it over to Dr. Andrini, and she's going to go over setting the stage, Houston Methodist story.
Thank you. Thank you so much, Mike Lewis. It's such a pleasure to be here with you today. So the Houston Methodist story started in 2017. And in that story, we started an accountable care organization with financial risk. It's the Medicare Shared Savings Program, Track 3, that is now called the Enhanced Track. And we decided we wanted to be good in value-based care. And that was a strategic decision for our health system because we really believe in improving quality at affordable costs for all patients, all payers. The only payer that started this program was CMS Medicare, which is why we enrolled in that particular program. I am joined by an all-star team who we have much to learn from that you saw at the very beginning. But if you look at this first slide, our whole infrastructure, actually from day one, our whole infrastructure was team-based infrastructure. We have teams that wrap around the patient because the patient is in the center of everything we do. The patient's in the center of everything we do. So when I say that, we work with a network of primary care physicians, over 300, both employed as well as private, and their attributed patients. At this point, that's over 50,000 Medicare fee-for-service patients. We develop quality dashboards because quality is the most important facet for us in this program, improving quality for a vulnerable population as they get older and they become more complex. And with that requires this team-based approach to wrap around them to support our primary care physicians. And so we have a nursing outreach program that is complex care for those patients with multiple comorbidities who may never have been admitted, but we think they have that possibility. We can follow them for 90 days with our nursing team to prevent that. And then our transitions in care for those high-risk patients post-discharge, we can follow them for 30 days to prevent readmissions, and our advanced illness care program for that population where we want to honor their wishes. We want to discuss advanced care planning. So that is all done outpatient-based to wrap around. But in all of our hospitals, we have our own case management team that does case management in a value-based care way, meaning patients actually get follow-up appointments before they leave the hospital. We address social determinants of health, non-clinical needs before they leave the hospital. And our case managers really develop relationships and trust with patients and their families because if they are readmitted, they're seeing the same case manager most of the time. So that's another important inpatient team. And then we have clinical pharmacists that wrap around these patients because as we know, the average number of medications an older person is on is much higher than we would want it to be. And so there's a lot of confusion about medication adherence, particularly after hospitalization, and side effects and cost of medications. And our clinical pharmacists actually help support that. And then one last comment. We couldn't do what we do without having a very robust analytics. Because when you have 50,000 patients, how would you know where to outreach, who to outreach to? How would you know? So we have very robust predictive analytics, and we are constantly mining data on our patients to learn what they're at risk for and how we can prevent it. And that's what drives our quality.
So Dr. Andrini mentioned our patient-centered care and talked about a little bit of our team members, the staff that we have in place. And I guess the question is, why those staff members? Why is it that team that we put in place? And the goal is to touch these patients wherever they go. We want our team to act as an extension of the primary care office. And so the case management team starts in the emergency room. Anytime a patient shows up to one of our Houston Methodist EDs, we get a ping, we get a notification that we need to either go down there, reach out to the physician in the emergency room and say, is there something we can do to get that patient to an appropriate next level of care? If they don't need to be admitted, what resources can we put in place to reduce the chance of readmission if we send them home with the right resources? So we have arrows going in either direction saying they could go home with resources and be referred out to one of our nursing programs, have appropriate home health set up and potentially some monitoring programs, or they could be admitted. If they are admitted, as Dr. Andrini mentioned, we have the same case managers and social workers who are trained in both disciplines, monitoring that patient and setting up discharge planning in a value-based care way. But what does that mean? It means I want them to go to the appropriate place at the appropriate time, looking for improved outcomes for these patients, not length of stay. I'm not trying to get them out as soon as possible. I want to know that I'm setting them up for success. for the full calendar year, and most likely they'll be our patient next year as well. So how can I work with this patient, their family member, and the primary care physician to make sure that we are going to get outstanding outcomes for this patient post-discharge? That may be going home, and if we are sending these patients home, we will set up follow-up appointments with the primary care physician and specialist if need be, or it may be going to a skilled nursing facility. We have a group of high-quality skilled nursing facilities that we put onto our map. We review it every quarter to make sure that these facilities are providing high-quality outcomes so that we can be sure when we're referring a patient to a skilled nursing facility, we want to make sure that we can tell them this one has good outcomes, you should most likely go here. Again, focusing on quality. The key and the reason that we have the arrows here is care coordination. That's why we're Houston Methodist Coordinated Care. Many times the ball is dropped when moving from one setting to the next setting. So we want to have those warm handoffs from ED to inpatient, inpatient to home, to skilled nursing, wherever they go. We want to make sure that we're maximizing the long-term health of these patients and having good outcomes overall. Next slide.
Great, thank you. Thank you, Dr. Mann. I'm gonna now concentrate on the quality data, and we're gonna move over to Wajia. So you get the slide over, go ahead, Wajia.
Thank you. All right, so now we're really going to talk about quality. Truly, quality, unparalleled quality is in the DNA of Houston Methodist Health System. And this slide represents Houston Methodist Coordinated Care ACO quality performance year over year since 2017 to 2024. And when you look at our trajectory since 2017, the improvement is significant in each quality metrics. This reflects a true transformation in care delivery and not just incremental change. Most importantly, when compared to the Medicare ACO national mean for the performance year 2024, we exceeded national performance across the preventative care measures, the chronic disease management, and behavioral health measures. So in today's MSSP environment, those margins is what's protecting our shared savings eligibility and really enforcing our competitive position. So I would really like to highlight that this level of performance is driven by strong primary care engagement, transparent provider consistently reporting and embedding our quality workflows and aligning our incentives to our clinicians. For us, quality is not a compliance exercise. It is our core strategy, and high quality performance strengthens our financial sustainability and reduces avoidable utilization and positions Houston Methodist Coordinated Care as a leading value-based organization nationally.
Great, thank you. Back to me. Sorry, my computer froze a little bit there. Let's move on and discuss how Houston has been doing with the savings rate, as well as taking a look at the ACO as a whole. So Dr. Andrini.
Thank you, Mike. We are super proud of this and have certainly celebrated this, that in the most recent outcomes reported by CMS, Houston Methodist Coordinated Care is #1 in academic medical centers, and there's some very illustrious academic medical centers on this list in terms of savings per patient. I also would like to draw your attention to quality scores too, because if you look down that list, what you'll see, there's only one quality score higher than ours. That one is 96.51 at Mayo Clinic, and we are 95.6. So I feel this is just terrific because we are an academic medical center. Sometimes there's a lot more complexity in academic medical centers, so we use this as a comparison, and we feel we have the right infrastructure in place to be successful and the right physician partners. And we've expanded our reach to work with other partners like American Heart Association, which you will hear about, because that is aligned with our goals to improve quality at the patient level in the practices. Completely aligned. And you'll hear more about that, because I think when you do these type of programs, You have to have the right infrastructure and the right expertise on your teams, but you also always have to collaborate with partners in order to achieve these kinds of results.
Great, thank you so much. All right, we're going to move from now into more of a panel discussion. So I'm going to have the screen drop away for you. And now we can go from where we are. Okay, so I wanted to start off with Veronica and Dr. Andrini. That was a great segue into what we were going to go into. This is the first time I've had the opportunity to work outside the whole MIPS and CQM and quality data with an organization, and it has brought such, it's almost prideful that we did this work together and with the American Heart Association and what we've done over the last couple of years. So Veronica, if you could give a quick description of what you've done with Houston Methodist to start, that would be great. Oh, you are muted. Hold on one second. There you go.
Thank you so much for the opportunity to share today. The relationship between the American Heart Association and Houston Methodist is a long-standing one. And by participating in the American Heart Association's Outpace Cardiovascular Disease Program, it really established a clear, consistent approach by providing data-driven, evidence-based tools to help standardize care, to help them identify at-risk patients, and to facilitate benchmarking. You know, the program enables consistent adherence to guidelines via the EHR data, looking at fostering cross-disciplinary teamwork and targeted actionable quality. So that's in a very high-level overview of the relationship between the two and how the American Heart Association brings value to Houston Methodist.
That's great. So the first part is when you're combining this information and you're working on doing this, a lot of the success came from working individually and breaking it down, but how do you think their approach has been to working on these programs with you guys compared to others that are out there?
The partnership is great. I've worked with all of Dr. Andrini's team, from Wajia, Jessica, Mamie. Everybody is we're all focused on the same initiative and on the same goals, is to improve quality health outcomes. And so, you know, we're really driving consistent quality improvement because we're looking at standardized data and benchmarking utilizing the EHR connected registries, such as the Outpace cardiovascular disease, and it allows for real-time reporting, allowing for benchmarking against their peer institutions. As Dr. Andrini shared in a slide before, you know, you're really not, you're not just looking at Houston Methodist, but how are you performing against your peer organizations, and then also working with them to adhere to guidelines. You know, this program facilitates the implementation of up-to-date guidelines for hypertension, cholesterol, and diabetes, ensuring that the consistent care of delivery is performed. And then just looking at the quality framework, you know, the programs foster a commitment to quality through structured, multidisciplinary and evidence-based protocols that reduce variation in care. And then we're just looking at those actionable metrics, such as get with the guidelines for inpatient care, and then also for Outpace CBD for outpatient care, making sure that everything is targeted towards specific initiatives, making sure that we are addressing things to reduce incidences of stroke and heart failure and AFib, and then focus on a roadmap for improving outpatient quality care. And so it's really been a great partnership to be able to bring all of the American Heart Association's research and to bring it to life through this particular initiative of Outpace cardiovascular disease.
That's great. Thank you so much for that. And what I wanted to share at this point is that I was very surprised and happy at how closely related the information that you need for this program links to what is needed for reporting through CMS for the ACO programs, and how at Healthmonics we were able to drive improvement and performance in your program utilizing the same measures that we're tracking for Houston as an ACO. And even last year, we were able to break it down by provider and all the way into the groups for the for the different practices that went in for the award. And would you or Dr. Andrini, how many of your groups had awards last year for this program? It was a lot. Trying to remember the LinkedIn profile.
I mean, I know
Over
from
200.
What was
Yeah,
it?
I was just going to say, Dr. Ginny, that we actually, and Veronica can confirm this, but we actually received over 200 awards between the two quality programs with American Heart Association. So we're so proud of that achievement. And particularly, this was the year, just to highlight the quality standards of our practices. This was the performance year 2024. And this was not the year where we were actively working towards driving quality performance across masses, all population. And to be able to achieve this level of performance, I mean, we were so proud of this achievement. So thank you for the collaboration, you know, with HealthMonics and of course, American Heart Association, and most importantly, Dr. Andrini for, you know, really bringing this idea to light, because to leverage our CMS quality reporting to participate in the American Heart Association.
And honestly, this is really driving improvement in blood pressure, improvement in type 2 diabetes control. And this year we're adding a new one that we're working on, lipids, cholesterol control. So we'll be doing that one in our submission this year to American Heart Association. And I can say the practices really, they frame this recognition. It's in the office space, so when patients arrive in the waiting room, they can see the American Heart Association recognition. It goes a long way for the practices, not only the physicians, the APPs and their staff, but also the patients in seeing that recognition. It really goes a long way. We actually celebrated it practice by practice and bringing these out to them. And we're so grateful that we could participate, we could aggregate this millions and millions of encounters through HealthMonics and work with American Heart Association to drive improvement.
That's absolutely fantastic. And someone that has been working in quality reporting for a long time, to be able to see how this relates to helping a patient at the end really helps drive what we do for a living. So I appreciated being part of this experience. All right, so we're going to move on. This one back to Dr. Andrini for this. How has your quality reporting strategy evolved over the last few years?
It has become quite more technical. We work in more and more EHRs. In 2017, we only had 5 aligned private practices, and now 25% of our PCPs are private practices working in about 13 different EHRs. So reporting on quality, given the many different EHRs that we have to report in, has become quite more complicated. The other thing, since the beginning in 2017, CMS has also changed quality metrics and has shifted from the quality metrics being applicable to our attributed Medicare patients to being applicable to all patients, all payers, which was their move toward equity in care, which we all value, so that all patients, all payers are receiving the same treatment. If they're not, then we're aware of that. So I think that's some of the biggest shifts. And my team, if they want to add to that.
100% agree with everything Dr. Andrini said, but most certainly, yes, the undertaking has been quite a journey, you know, integrating data from all these 13 EHRs. So absolutely.
That's great. The next one, once again, back to you, Dr. Andrini, but where do quality goals most often conflict with operational or clinical realities? You have a long-standing history working with patients and now dealing on this side. Where do you see that conflict?
Okay, one comes to mind in particular. Certainly everyone wants to improve quality. All of our providers, physicians, APP staff, everyone has good intention to improve quality. Sometimes it becomes operational conflict, and we actually conquered this one. is when we had to do depression screening, for instance, in all of our patients. And all of our patients once a year were not receiving depression screening. So we had to figure out how to do this to support our practices. And I would always recommend to do this using technology, not pieces of paper in the waiting room. So we integrated it in the EHR so that depression screening became like one of the vital signs with our medical assistants. And we trained our medical assistants to ask 2 questions. And so the medical assistants do the blood pressure, do the vitals, and now they have those 2 questions so we can assure that everyone gets screened. So you have to think strategically when in operations of how can you make this easy, simple, and integrate it in a clinical workflow that already exists. I think that's really key for operational efficiency and effectiveness.
That's great. And when you have the PHQ-2 score, which is what you're talking about with the 2 questions, and then someone scores high on that, then the provider comes in and does the rest. Is that how it works within your facility? Or?
You're absolutely right. So if the PHQ-2 is positive, then the MA who works with that physician lets them know so that they can do the PHQ-9 and the follow-up, making sure that they have a follow-up plan for that patient.
That's fantastic. All right, we're flying through these questions, but on to the next one. I'm going to point this one at you, Wajia. What has been the hardest part of producing accurate submission-ready quality data?
Wow. So yes, many challenges come to mind. One of the biggest lessons truly we have learned is that producing accurate submission-ready quality data for MIPS CQM reporting, this is the type of reporting is the most appropriate for our structure. So it's MIPS CQM reporting, and then also we're also going to do Medicare CQM reporting for the performance year 2025. But really, it's so much more complex than just simply measuring performance. And the hardest part is really translating the care that happens at the point of encounter into the very specific data structure that CMS requires for quality reporting, since it's all electronic. And so number one challenge really is the bridging the gap between the clinical care and then the reportable data, right? So first, there's often a gap between how clinicians are naturally documenting care and how quality measures are required to be captured for reporting, because we really have to ensure that the data lies in the discrete field. And so our physicians may absolutely perform the right clinical interventions, but if those activities are really not documented in those structured fields, then it's not captured in the quality data. So one of the biggest efforts for our ACO has been aligning the clinical workflows with the structured documentation that supports the CQM reporting, but not only in one EHR, but across multiple EHRs, customizing to how the workflows are structured in those specific EHRs. And then, so the second challenge that really comes to mind is managing the complexity of the data integration. And so again, the complexity of data itself is very complicated. Even within a highly integrated health system like Houston Methodist, quality reporting requires really pulling data from multiple sources. Like we're looking at our lab systems, claims feeds. I mean, it's really is coming from, we're using care everywhere. I mean, data is traveling through all these various sources, but ensuring that all of those data sources are integrated, standardized, and then aligned with CMS measure specifications really requires a strong analytics infrastructure and ongoing collaboration between clinical operations, IT, our population health teams, and most importantly, of course, all of our clinical operations, leadership, our clinicians, their MAs, but also, a partner like HealthMonix. And then the third thing I would like to mention is really interpreting and maintaining these CMS measures that just kind of seems to tweak a little each year. So that is definitely another significant challenge in the complexity and the evolution of CMS measurement specifications. And really to point out the requirements around patient eligibility, the numerator and denominator logic, exclusions and exceptions, coding requirements, I mean, you name it, right? But again, most importantly, our teams are consistently, reviewing data, validating data, so it's quite an undertaking. And then also one thing to point out is ensuring, as we are looking for submission, ensuring data accuracy. Before any quality data is submitted, there's such a rigorous validation process. This was very new to us because, again, we moved from just reporting quality for MSSP a population through web interface to all patients through this electronic submissions. So for our ACO, that meant reconciling our internal dashboards, our registry outputs, ensuring that patient attribution, our measure eligibility, performance results are all aligned, and it's depicting accurate representation of the performance from the EHR to the HealthMonix quality reporting dashboard. And then lastly, and this is going to be my last point, is that most importantly, our provider engagement. So quality reporting ultimately reflects what happens at the point of care. So ensuring that providers understand how their documentation supports quality measurement is ultimately the success of their and representation of not only their work, but the success of the ACO. And this is such an important focus for us.
Great, that is a great answer. And I think one thing working with you guys has been very interesting. We've all learned what QRDA1s and different types of spreadsheets and Excel files, a lot more about them than we ever thought we would learn over the last 4 or 5 years. So your team does an excellent job of deciphering between and how it needs to be sent from each of the different EHRs and what we can use for it. So much appreciated. I wanted to move on to the next question, was what workflows or process changes had the greatest impact?
Wow, again, great question. So from the perspective of our Houston Methodist Coordinated Care, accountability for quality performance has to be structured in a way that supports physicians rather than creates friction, right? Like that's just at the ground level. So in an MSSP ACO environment, success really depends on engaging our clinicians and the practices as partners in population health. So first, we focus heavily on transparency and performance data. We meet with our ACO practices on a monthly basis, reporting to our physicians and practices their quality performance along with their care gaps and how they compare to the ACO goal for each metric. So we're not settling on the benchmarks that the CMS has placed in place. Actually, we have really raised the bar to prepare what's forthcoming. So the key is making the data actionable, right, and timely, so practices can address their care gaps before the end of the performance year. No, we're talking about large populations, so being very proactive from day one of the year. Second, we align incentives. This is a big one. We align our incentives with quality outcomes. So Houston Methodist ACO shared savings distribution is really tied to quality performance. When physicians see their preventative, when they see that preventative care, chronic disease management, and patient experience directly influence the financial success of the ACO, accountability becomes aligned with the broader mission of really improving patient outcomes. And so for my third point, I really have to point out that we invest in infrastructure that helps practices succeed. And that is our core. Throughout the ACO, we provide population health analytics and operational support to help our practices close care gaps. We don't just kind of provide them with the materials and say, okay, well, it's on you. This is a true collaboration. And we're there at every step of the way, and every single patient matters for this purpose. So this is especially important for smaller practices that may not have the same internal resources. Okay, so that's very, very important to us. And finally, we take a very customized approach to accountability. If a practice is struggling with performance, the first step is really coaching and supporting, reviewing their workflows, identifying what those barriers are, and really connecting them with the ACO resources to ensure that we are setting them up for success, because their success is ultimately the ACO success.
That's fantastic. All right, I'm going to change it up a minute here and go to a question from the crowd, but this is going to go over to Dr. Men. If you're starting your ACO today, what would you do different?
Ooh, that's a good question. I feel like we've had so many learning opportunities. So I think in starting without the experience, you stumble through a few things, and it's actually made us more nimble, a bit, kind of able to change with everything as we measure the quality outcomes or the clinical outcomes. We say, oh, we're going to change and try this new process. And I love that we're still 10 years into this in a very nimble ACO. But if I had to pick something, with most of the clinical programs rolling up under me, I would probably start our inpatient team a little bit earlier. I think having the inpatient case management team really focusing on those discharge planning in a value-based manner has led to reducing readmissions and reducing the excess overutilization of days that are putting patients in the wrong level of care. Our team is assisting in getting them to the right level of care, which ultimately is helping the patient and helping the physicians. I think that, with an ACO being not just a quality incentive program, it is truly a value-based program. We get the engagement from the physicians by going out and talking about quality. Here's how you're doing, here's how we're helping you with quality, but overall, here's your patient. Let's get down to the patient as a whole. We are helping to make sure that patient is going to the right level of care. I'm assisting with setting up a follow-up appointment with you. I'm making sure everything is in place for you. And I think having those touch points wherever we go has been very helpful. We started our inpatient program, I want to say in year 2, and it was with just one case manager, even though we had 7 hospitals, and we had to show the success of that in order to fund having more inpatient case managers at each of our facilities. So it was a stair-stepping process to build up a large enough team, but hindsight being what it is, I would love to have just a full team ready to go, making sure we can help with that care coordination back to the physicians.
That's great. And Dr. Andrini, do you have anything to add? What would you do?
I have one thing to add that was a learning for our team, and it has to do with physician engagement. We did very well on engaging physicians by linking quality to incentives, but I would also engage physicians very early on getting credit for complexity of patients they see. And that has to do with risk adjustment factor, or has to do with when you're coding your patients, capture the complexity of the patient, get credit for that. And the reason I say that is because the only language that CMS recognizes is claims. So when they look through the claims of a population and they calculate, this is how many dollars on average per year we're going to give you to take care of a population, that will only be increased if you have a more complex patient population. And one of the learnings we had is we weren't capturing the complexity of the patient population, and we're still working on that. That was a new learning for the physicians and for us, because when you enter value-based care and take financial risk, you want to make sure that you are actually receiving the dollars it takes to take care of a patient, and then preventing those readmissions, those avoidable admissions, decreases your expenditures. This is the formula, and that is how you earn savings, right? And so if you start with a lower benchmark, you're gonna have lower savings, and actually you're not getting credit for the complexity of the patient. So I would start that education a lot earlier, and it's a tough one because it changes too every year. But we've been working on that, and I think we made a lot of progress. That was a big learning, really. That wasn't on our radar till almost at the end of the first year.
That's great. That's great. All right, sticking with the same, we're actually going to go right back to you, Dr. Men, on this next one. What reporting or scoring surprises have you encountered that force you to rethink your quality strategy? Oh, this is a great one. I love that question.
This is a great one, and I'll let Wajia jump in as well. I want to make sure we all have our chance to throw our voice in for this one. As far as surprises, I think kind of at least area that I was most surprised about is kind of the depression screening, I would say. I was surprised that we weren't scoring as high as we thought, and to Dr. Andrini's point, making it something that we could involve the MAs in, changing the workflow to make it something that is not just extra put onto the physician, was helpful in engaging, making it kind of a hard stop. This is done on every single patient. We made it part of the rooming process. We made it where it was a defined field. That was something I was actually surprised to see how much of a jump we were able to get by just putting in one defined process that's done by the MAs. It's done in the rooming tab. And it made just a huge impact in our performance overall, which gave us ideas of, you know, what else can we do at a standardized level that is not putting more work onto the physicians. It helps them to get engaged, showing that us doing something, partnering with somebody else as part of your team, is jumping your score up, and that helped to bring in a lot of engagement from the physician. So happy to see one small little tweak actually led to such a big jump in our performance. Would you, Dr. Andrini?
Yeah, I can kind of add, and Dr. Mann, you're just spot on in regards to, you know, what we kind of projected where the struggles would be, because when we're talking about all population, we were concerned that this depression screening is the metric where we're not going to be able to see the level of performance, because, you know, heavy focus over the years, just MSSP patients. So this was a surprise element for us. But I must tell you, everything that Dr. Mann said in terms of standardizing that workflow really empowered our clinicians. And when we talk about our 2025, kind of, we're working through our perfecting our performance in terms of accuracy of the data. But when we look at our primary care clinicians' performance as an aggregate, we're well above 90% performance rate for depression screening. I mean, that was the surprise. It was just like it really blew us away. But again, you would think that, okay, in addition, what were we doing differently? So one of the strategic ways of how we drive you know, our clinicians and practices towards meeting these standards and goals is that we incorporate healthy competitions. And so very early on into the year, like I'm talking about, you know, like we set in an ACO level competitive recognition for our practices. And we said that, okay, so our highest performing practices, and we have it grouped by their patient panel size. So by practice size, we're going to, you know, award them with, you know, lunch, so on and so forth, goodies and so forth. And so this went from like January 1st to like May 31st, call it. And then, you know, what we did is we precisely focused on depression screening, because we knew this is where we're going to struggle. And lo and behold, our performance started uptaking. Everyone became so serious about standardizing those clinical workflows. Again, you know, they're listening to us, but then now they're really honing in to compete with their peer practices. So definitely wanting to highlight our strategy in terms of driving towards success.
Yeah, don't ever underestimate the competitiveness of physicians.
That is so true. And just to speak to that excellent point, and when we first started in 2017, we made the decision when we went to the practice meetings to show all quality metrics unblinded. All physicians in the practice saw each other's quality scores every month in the practice from day one. That was a cultural shift, but we put that in place from the beginning because we knew we could leverage and they could learn from each other. And then we have those healthy competitions. But, you know, two other surprises I was thinking about is when CMS shifted from the Medicare quality metrics to all patients, all payers, I think we were all thrilled what a high quality primary care network we had. Because the shift from just a very discrete population of Medicare patients to all patients, all payers, they did just as well in all patients, all payers, if not better, than with a subset of the Medicare patients. And we were thrilled to see how incredible they are. And then the last point I want to make is about blood pressure. I think we learned about blood pressure in that surely everyone doesn't have a blood pressure of 140/90. It just doesn't quite make sense, right? But somehow, you know, we were seeing that. And we thought, well, we have to do some education. This is where we worked with American Heart Association and brought up posters on how do you take blood pressure when a patient enters the office. And we also implemented home blood pressures, that if the blood pressure was elevated, what was their home blood pressure? And follow-up visits. Our PCBs do a lot of follow-up visits on blood pressure control and home blood pressures. So I would say we learned a lot about patient-reported outcomes, educating patients to know their numbers, educating patients, you know, in that way, and using that data.
That's great. And you know, all of these metrics that you guys are tracking are just so important because it's the base level to start saving people's lives and really, you know, making an impact on them, reducing heart rate, diabetes, checking on their depression, cancer screenings, and so forth. I think that CMS has actually done a really good job of narrowing those measures into really the most impactful things when you're talking about a practice in the ACO. All right, we're going to move on to the next one so we can keep this going. This one's for you, Dr. Mann. How are you preparing your quality reporting strategy for future shifts in CMS programs and increased measurement complexity? You know, there's some fun stuff that's coming down the lane, whether it is through the ACO or some of the new programs like ASM and Access and Guide. There's a lot that, you know, ACOs kind of, especially for their Medicare, have been sitting in the quality data just for the Medicare patients. Now you're going to have providers that may be eligible in multiple different programs within CMS. So what are you saying?
So for us, it was very important to kind of separate out and take a look at the physicians and which programs that they would qualify for. When we started our accountable care organization, we had one tax ID number for our primary care physicians and our specialists. They all billed under one tax ID number. Where that started to hit us is where we have specialists seeing patients that may not be going to one of our primary care physicians. And so now all of a sudden they come for one specialty visit and we're on the hook for breast cancer screening or for an orthopedic surgeon, right? And so we wanted to make sure in the future, as we move towards all patients who had a qualifying encounter and all quality metrics, no matter, you know, the payer, we wanted to separate out our specialists and our primary care physicians. So our primary care physicians are now on the hook for every patient that they see and making sure that they are doing what is within their scope. And we separated out the specialists so that they can practice within their scope. With some of the newer programs coming down the line, like the ASM, the ambulatory specialty model, if that applies to a specialist, it will be within that tax ID number and they can stay within their scope of practice. So I think just making sure that we were not asking people to operate outside of what is their normal practice has been helpful in making sure we're looking kind of to the future of who we're being held accountable for and all the patients that we're seeing.
That's great. That's wonderful. We ready to move on to the next one? This is I think this is our last big question. Then there's some smaller ones that are there, but what advice would you offer to other health systems? You guys have done such a tremendous job of I mean, the story you tell from that day one in 2017 to almost 10 full years later and where you stand right now. It's complex. Let's start with Dr. Andrini, but where do you tell them to start? It's not easy.
I think to start, you have multiple stakeholders and you have to explain and educate in value-based care what it means to a patient and what it means to these multiple stakeholders, whether they're financial, whether they're legal, compliance, CEOs of hospitals. You really have to message to them what you're trying to do and align with them on some common bonds or strengths so that they know how this fits into their picture. And in order to do that, you really have to have support from the very top. Like I mentioned, this was a strategic strategy from our chief strategist, right, under the CEO of the health system, to be good at this, to learn this, to be good at value-based care. And this was a strategic system strategy. So you have to have that, because if you don't have that, how are you going to build any infrastructure? And as you heard Dr. Min say, we had one case manager because we had to make the business case, the financial case for each of the people we hired. And so you have to have that support in order to build the infrastructure also. And you have to communicate differently to different stakeholders. You have to really be able to speak their language and understand their needs and why this may be a conflict to them or maybe welcoming to them, and early on address that early on in order to be successful. And I'm sure my team has their own perspectives, but the first one that came to mind for me was the multiple education and presentations to the system board, to the CEO leaders, to all of these people, so we were all aligned and understood what we were trying to do.
Great. Dr. Min, do you want to add on to that?
Yes, I would say move quickly, be nimble. There's a lot of, and use your data. You know, use your data to guide you as to what your new initiative it is. Measure, you know, kind of repeat, try something new. I think to Dr. Andrini's point of, you know, you've got to have the stakeholders in place. Use your data to get the buy-in, mostly from your physicians as well. You need the buy-in at the top, but your physicians are the ones that are, you know, guiding the program. It's their patients that are there, so use the data to get them on board. They're scientists by background, right? Show them the scientific proof of we need to do this because this is the outcome that we get. But at the same time, you've got to move quickly. Don't get caught in the analysis paralysis, right? See where the data is showing you something to do, put something in place and try it. And then, you know, kind of iterate. If it's not working, try something new that's close to it, but you've got to keep moving forward or you're not going to move at all.
Perfect. Lucia?
So I'm going to just kind of piggyback off of what Dr. Min said in the realm of physician engagement, because that's my space. What I would, you know, say that from my experience, really connecting with your clinician at one-to-one level, it really empowers them to drive that performance. It's there. Sometimes, you know, in group setting, they're really listening to you, but then, you know, many times they need that one-on-one approach. Connect with them and you will see how they're going to move mountains. It's going to work. It's been effective time and time again, but really, you know, try that. Do not give up. Our clinicians are our superstars and they will make it happen, but we really have to take this approach in connecting with them, empowering them, and they're going to be our stewards to drive this to the next level.
That's such a great story and great impact there, for sure. Okay. I have a couple questions from the audience, but before I go there, I want to tell the panelists, I'm going to ask you at the end for parting shots. Everybody gets a minute or two to kind of what you want everybody to leave this webinar thinking about and knowing. So we'll go to that in a minute, but I do have a couple of questions that I wanted to run by, and feel free, whoever it is, to answer. The first question is, how do you get all of this work done while the rodeo is going on across the street?
You stay late because it's not worth trying to leave at 5 o'clock. The traffic's ridiculous. And head in any other direction. Even you can see the stadium outside of our window, just head the other direction.
Yes, my drive in this morning was very interesting because of the traffic from the rodeo. So that's great. If anybody doesn't know, the rodeo happens once a year for a whole month down here, and it is just really busy. I've heard it from everybody I've talked to. All right, next one I have, and anyone can answer this, is, you know, every organization, whether you're healthcare healthcare IT, AI is really, like, you know, everybody's like, oh, what are you doing with AI? I'd love to find out from the Houston Methodist team what your, you know, basic thoughts, not too deep. And Veronica, if you have anything to add about what the American Heart Association is doing with AI, that'd be fantastic.
Well, we have piloted work with AI care coordination. We have done that. because we can't continually add staff. So if there are non-clinical needs that can be met with the AI and some way of care coordination, it completely makes sense because we can manage more patient needs because they are tireless workers that work all hours, AI, and it's not more people. So we can accomplish a lot if we use it appropriately for non-clinical needs linked to clinical care. And that's where we have seen that. Other place in a health system where we've seen is repetitive tasks, revenue cycle, repetitive tasks. They've used AI. And I think we're going to see more with that coming. I always think, though, whenever we talk about AI, it's really, AI is a tool that also needs the human touch and knowledge. It's just a tool. I don't think it's going to replace, particularly in healthcare, the thought processes and the compassion that go with the human touch in caring for a patient.
I hope not. When I go to my doctor, I like to talk to my doctor. Anybody else want to pop in? Or Veronica, what are the thoughts on the American Heart Association, what they're doing with AI?
So as it relates to the American Heart Association, we have a whole division focused on AI and how it's going to play out. But I think that the one thing that I would say is that we never want to take away the human element, right? We always want to have that human element and not have it think for us, but also developing and working with organizations that develop tools to make the work easier, to capture that data, to be able to analyze the data, and to help us streamline workflows and standards of care. But we are working very heavily. And one of the things that I'm very proud to say is that the rigor that we evaluate all the different things that come our way with looking at different organizations. We really do a great job of making sure that we elevate those organizations that have met that rigor, and we celebrate them at scientific sessions on an annual basis. And so excited to see where it takes us in the future, but we are building that out.
Great, that was awesome. So it kind of stole a little of our time everybody gets a minute now. So let's start with Dr. Andrini. Can you give me a minute? What's your biggest takeaway you want everybody to leave here with?
I would say be passionate about the work that you're doing because you're taking care of people's lives. And so it is very gratifying, very complicated. And Dr. Men, be nimble, be agile, also embrace change that improves care. All those things are critically important. But then I would also add, you want to have the right people. You want to have the right people, the right physicians, the right team members. I mean, I am completely grateful. I feel I have the dream team because everyone is just as passionate and committed and accountable and respectful and all of the great traits you would want on a team. And you want to have that kind of team so that you can celebrate your success, because I want to wish everyone all the best in their own journey.
Perfect. Thank you. All right, Dr. Men, you want to go next?
Sure. I would say focus on the patient. We talk about quality a lot, and quality is very important, but we always have to relate it back to the patient. I think engaging physicians, it's important in a value-based program, kind of toot your own horn and celebrate the successes of, hey, we just did this for your patient, provided all of these services, right? Remind them kind of the robustness of the program, whereas a lot of quality is making sure, you talked about it before, setting up the right connections, making sure we're getting the information from wherever it is in the EHR over to Medicare, which at times you lose focus of this is good for that patient. And you have to be able to bring back all of the success stories of what it means for these physicians to be in an ACO, to be in a Medicare Shared Savings Program. These are extra resources that are providing better outcomes for your patients. So don't lose sight of the patient. It's one of the best ways to keep your physicians engaged, and it's the best thing to do in a program like this.
Thank you. All right, Wajia, your turn.
Wow, I feel like Dr. Men And Dr. Andrini had said everything that was on my mind, but really, really standing behind, everything that they said. But I think one advice it would be that, especially in this type of complex environment and workflows, really don't reinvent the wheel. I think it's important that we are really collaborating and learning from each other, working smarter and not harder. And it has to be a team-based approach. And we talked about how we really are nothing, without our incredible team in every direction, and so, yeah, I mean, and at the end of the day, do self-care, take care of yourself, because if we are stronger, that's how we're going to be able to take care of others, and most importantly, being there for our patients.
Great, thank you. And Veronica, any parting thoughts today?
To just say, if you're not already leveraging our 100 years of research and evidence-based resources and programming, please reach out to us. We're happy to help all organizations, both on the inpatient and the outpatient side.
Great, and your information will be available if you reach out to me. I'll be able to get you guys forwarded on my email addresses all over the invites and on our on our webpage for that. My final thoughts here as we close this out. First off, I want to thank our panelists. You guys are great. You are wonderful to work with. And I'm excited about even what the next steps are and where we go from here as these programs become complex and they change every year, change last minute. There's lots of things that come at you guys, and you're a great team to work with. To me, I think the biggest takeaway that I have that I'd like to share is you guys turned what I used to call click quality, which is you click the right button in the EHR to get the data that you needed for these programs into patient care. And that is so, I don't know how unique it is out in the market, but it is a great feeling and it's a great organization to work with when we do these things. So I'm proud to partner with you guys and very happy to be here in Houston with you. And thank you so much. And everybody, have a wonderful rest of submission season. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.